This video is about nursing education for linezolid drug administered to pediatric patients, done by student Halia Ibrahim, supervised by Dr. Abir Ayoub in the Faculty of Pharmacy at Jordan University of Science and Technology. What is linezolid? Linezolid is in a class of antibacterials called oxazolidinins. It works by stopping the growth of bacteria. It is active against the vast majority of clinically important gram-positive cocci, including vancomycin-resistant Enterococcus, as well as methicillin-resistant Staphylococcus aureus and high-level penicillin-resistant Streptococcus pneumonia. It is available in Jordan as Zyvox, Zersa, Linezolid, and Joswititeria. The available dosage forms are tablets, oral suspension, and injectable solution. Linezolid is metabolized by the liver to inactive metabolites excreted with the parent substance by the kidney. Parenteral dosage administration in pediatrics. For parenteral intravenous administration, check the infusion bag for minute leaks and solution for particulate matter prior to administration. If leaks are detected, discard the solution as sterility may be impaired. Additives should not be introduced into the solution. Administer without further dilution over 30 to 120 minutes. If linezolid intravenous injection is to be given concomitantly with another drug, each drug should be given separately in accordance with the recommended dosage and route of administration for each product. When the same intravenous line is used for sequential infusion of other medications, flush the line with dextrose, normal saline, or lactated ringer solution before and after infusing linezolid. The yellow color of injection may intensify over time without affecting potency. Diluents. Compatible intravenous solutions include sodium chloride injection, dextrose injection, and lactated ringers injection. General dosage in neonates. Linezolid is not a preferred agent in the treatment of infections requiring prolonged therapy due to the risk of serious hematologic and neurologic toxicity. The use of linezolid is generally reserved for treatment of infections due to drug-resistant organisms. Intravenous general dosing for susceptible infection according to Red Book 2012 in neonates with body weight less than 1 kg, in PNA less than or equal 14 days, 10 mg per kilogram per dose should be received every 12 hours. In PNA from 15 to 28 days, 10 mg per kilogram per dose should be received every 8 hours. In neonates with body weight from 1 to 2 kg, PNA less than or equal 7 days, 10 mg per kilogram per dose should be received every 12 hours. In PNA from 8 to 28 days, 10 mg per kilogram per dose should be received every 8 hours. In neonates with body weight more than 2 kg, 10 mg per kilogram per dose should be received every 8 hours. General dosage in pediatrics. Linezolid is not a preferred agent in the treatment of infections requiring prolonged therapy due to the risk of serious hematologic and neurologic toxicity. The use of linezolid is generally reserved for treatment of infections due to drug-resistant organisms. General dosing for susceptible infections, mild, moderate, or severe, intravenously. In full-term infants and children less than 12 years of old should receive 10 mg per kilogram per dose every 8 hours. Maximum dose is 600 mg. In children older than 12 years and adolescents, 600 mg should be received every 12 hours. Dosing in renal impairment. For renal impairment in pediatrics, no adjustment is recommended. The two primary metabolites of linezolid may accumulate in patients with renal impairment, but the clinical significance is unknown. Weigh the risk of accumulation of metabolites versus the benefit of therapy. In infants, children, and adolescents, the following adjustments have been recommended according to Aronoff 2007. Note that Rene adjusted dose recommendations are based on doses of 10 mg per kilogram per dose every 8 hours for ages less than 5 years or every 12 hours for ages from 5 to 11 years. In children undergoing intermittent hemodialysis, 10 mg per kilogram per dose of linezolid should be administered every 12 hours. In children undergoing peritoneal dialysis, 10 mg per kilogram per dose of linezolid should be administered every 12 hours. In continuous renal replacement therapy, no adjustment is necessary. Dosing in hepatic impairment. For hepatic impairment in pediatrics, in mild to moderate impairment, Child-Pugh class A or B, no adjustment is recommended. In severe hepatic impairment, Child-Pugh class C, use has not been adequately evaluated. Common adverse events include gastrointestinal, diarrhea, abdominal pain, dysgeusia, loose stools, nausea, oral candidiasis, tongue discoloration, and vomiting. Hematologic and oncologic, decreased platelet count, decreased white blood cells, anemia, decreased neutrophils, eosinophilia, thrombocytopenia. Dermatologic, pruritus, endocrine and metabolic, increased amylase, increased lactate dehydrogenase, genitourinary, vulvovaginal candidiasis, hepatic, abnormal hepatic function tests, increased serum alanine aminotransferase, increased serum alkaline phosphatase, increased serum aspartate aminotransferase, increased serum bilirubin. Infection, fungal infection. Nervous system, dizziness and headache. Renal, increased blood urea nitrogen, increased serum creatinine. More adverse events. Post-marketing experiences include cardiovascular, such as hypersensitivity angiitis, dermatologic, such as bullous skin disease, severe dermatological reaction, Stevens-Jones syndrome, toxic epidermal necrolysis, endocrine and metabolic, such as hypoglycemia, lactic acidosis, gastrointestinal, such as Clostridioids difficile-associated diarrhea, and staining of tooth, hematologic and oncologic, such as bone marrow depression, leukopenia, pancytopenia, and sideroblastic anemia. Common drug-drug interactions. Linezolid inhibits monoamine oxidase. Linezolid should not be used in patients taking any medical product which inhibits monoamine oxidase A or B. Aminosalicylic acid derivatives may enhance the myelosuppressive effect of myelosuppressive agents. Agents with blood glucose lowering effects. Monoamine oxidase inhibitors may enhance the hypoglycemic effect of agents with blood glucose lowering effects. Amphetamines. Monoamine oxidase inhibitors may enhance the hypertensive effect of amphetamines. Antiemetics may enhance the serotonergic effect of serotonergic agents. Common drug-drug interactions. Antipsychotic agents. Serotonergic agents may enhance the adverse toxic effect of antipsychotic agents. Serotonin receptor antagonists may enhance the serotonergic effect of monoamine oxidase inhibitors. Sympathomimetics. Linezolid may enhance the hypertensive effect of sympathomimetics. Tricyclic antidepressants. Linezolid may enhance the serotonergic effect of tricyclic antidepressants. This could result in serotonin syndrome. Typhoid vaccine. Antibiotics may diminish the therapeutic effect of typhoid vaccine. Methyl-dopa monoamine oxidase inhibitors may enhance the adverse toxic effect of methyl-dopa. Monitoring parameters include CBC weekly, particularly in patients at increased risk for bleeding, patients with pre-existing thrombocytopenia or myelosuppression, patients with chronic infection who have received or who are on concomitant antibiotics, or concomitant medications that decrease platelet count or function or produce bone marrow suppression, and in patients requiring more than 2 weeks of therapy. Number and type of stools per day for diarrhea. Visual function in patients requiring more than 3 months of therapy or in patients reporting new visual symptoms. Storage and stability. For infusion dosage form, store at room temperature, 25 Celsius or 77 Fahrenheit, and protect from light and freezing. Keep infusion bags in overwrap until ready for use.